the people organizing the meeting asked me to talk about some newer forms of radiotherapy. Radiotherapy has always been a technology-driven field, and the technologies have improved really dramatically, especially with faster and more modern computers, and they're driving these machines that can highly focus radiation to specific spots in the body to try to target the cancer. Historically, radiotherapy caused a lot of collateral damage. That is, the fields would often encompass a swath of tissue throughout the body, causing just as much normal tissue injury as it did targeting the cancer. But these newer techniques are able to focus the radiation specifically at the tumors, even tumors that are moving, and target them without much normal tissue exposure. And it's only getting better with things like charged particles, protons, carbon, things like that, to the point where the collateral damage is really minimized. So these technologies are expensive, and so one has to make sure that they're worth the added cost. Historically, radiation oncologists unfortunately didn't do many clinical trials. They just basically had new technology, touted its benefits without confirming it in clinical trials. We're not getting away with that anymore, and so the expectation is that we'll do clinical trials. So one in particular, called stereotactic ablative radiotherapy, has been shown in early clinical testing to be quite significantly better at treating early lung cancer, that is stage 1 lung cancer, where it's quite limited. This is a cancer that has been treated with surgery for decades. A very good treatment, but at a significant cost to patients. It's simply hard on the patient to have a big surgery like that. And many people with lung cancer are already having frailties that make that operation difficult. So this is a completely non-invasive outpatient treatment, typically done in 1 to 3 or 5 treatments, which is very different than the conventional radiotherapy, which is 6 weeks or 7 weeks of daily treatment. So in the early clinical testing of this stage 1 lung cancer, it was shown that tumors could be eradicated that were aimed at with a therapy with a probability of over 90%. And that, of course, rivals surgery. Not a perfect therapy. Sometimes when the tumors were very close to the center of the chest where the airways branch off, there was more toxicity. But this was a dramatic difference than historical non-invasive treatments that had control rates in the 40 to 50% range. So that's been extensively now utilized throughout the world, and I think that there's pretty much buy-in that this is a very nice alternative, especially for the patients who can't tolerate surgery, and there are many of those. But what I'm talking about at this conference, which is really exciting for us, is we decided to use this therapy in the other end of the spectrum, that is people with metastatic disease. And these patients, of course, have dismal survival rates. Historical use of systemic therapies like chemotherapy have been able to maybe shrink some of the tumors some of the time, but pretty much no chance of cure and very short survival. For example, in patients who are first diagnosed with metastatic lung cancer, the median survival is under 6 months. So the tumor is unrelenting and often leads to a quick demise of the patient. In the past, surgery has been used to try to treat metastatic disease, and surgery also, like the SABR treatment, is a local treatment, but at a fairly high cost. And so when patients had their metastatic disease resected, they often ended up with long hospitalizations and difficulty in recovery. Some patients were cured, though, leading to an excitement about something we call oligometastatic disease, or few tumors instead of the widespread metastatic disease that also exists. This new treatment, though, might not be so costly for the patient, and so we tested it in a group of patients with metastatic lung cancer. These were sort of the worst of the worst. They had already had progression on conventional standard chemotherapy like platinum-based treatment, and we decided to treat every tumor that was visible on scanning with this SABR treatment. We treated 24 patients in this phase 2 pilot study, rather modest doses of the stereotactic ablative treatment, the SABR treatment, which therefore didn't lead to much toxicity. And typically these patients have a median progression-free survival of 2 to 3 months. And in this pilot trial, they had a median progression-free survival of nearly 15 months. This is really a dramatic improvement. Some of the patients are out 4 and 5 years without progression. I'm not saying they're cured, but by adding this local therapy, we did seem to extend their progression-free survival by a lot. This was coupled with a drug called erlotinib, which is a molecular targeted agent that had already been established in that role, but it dramatically improved their results. And so this new sort of model of adding a local therapy to an already established systemic therapy may have legs. And I think that it does make some sense. The systemic treatments have always thought to be best against microscopic disease because they do struggle with tumor bulk. In many studies, the first site of progression in patients treated with chemotherapy or targeted agents is often the sites that were already visible when they were enrolled to the treatment. And so if you can add to that a little help, a little extra nudge from a local therapy that's not so costly, this actually makes a lot of sense and may sort of be the extra effort that causes a cure or improved survival. And the first step with lung cancer, which is a tough disease to treat, most people would have been skeptical that this was the right model to use. But there's so many patients that it just made sense to us to at least try it in this dismal disease. So we're moving on to diseases that might not have quite such a heterogeneity of tumor type and poor prognosis. So there's trials now being done in breast cancer, which has similar patterns of relapse. And importantly, we're looking at pediatric cancers to try to cure children who have metastatic cancer. So the first step is to confirm that indeed the local therapy can be added safely to the systemic treatment, and then conduct the clinical trials, initially comparing it to historical results, but later we'll do more high-level evidence of testing. So conventional radiotherapy has used these very small daily doses and therefore adding them up over many days. And so like I say, the typical treatment course for conventional radiotherapy is a month or 2 of daily treatments. The reason that that was done was when more short courses were used historically, and I'm talking about almost 100 years ago, there was severe toxicity mostly related to the fact that the technology couldn't differentiate the tumor from the normal tissues. And so a treatment that can kill a tumor can obviously also kill normal tissue, and therefore there was no therapeutic benefit. You hurt the patient just as much as you help them. So these small daily doses were used to try to exploit slight differences between normal tissue's reaction to the radiation and the tumor's reaction to the radiation. And this was done for decades with this technique. And it really limited the ability of radiotherapy to make an impact short of mopping up after surgery or something like that. This new treatment, though, utilizes technologies that allow the dose to be highly localized using very small fields, often hundreds of fields. Each field doesn't cause much entry or exit damage, but they're precisely localized on the tumors, overlapping there to where they can really push hard on the tumor itself. Tumors move, and so accommodation has to be made for the motion of the tumor. That historically was not done, or in the past it was just that the field was expanded to deal with any motion. But this, of course, adds to the toxicity, and so these new techniques track the motion or account for it in a more sophisticated way. And then most importantly, giving the treatment in what's called hypofractionated or oligofractionated fractions, where only 1 to 5 treatments are given rather than 30 to 40 treatments, dramatically increases the potency of the treatment at the site where the beams actually overlap. It would cause great harm to any tissue that is in the sites, but hopefully it's only the tumor and limited other tissue. And in this way, we've learned through the clinical trials that we've done how to deal with the tissue on the edge, that is the adjacent tissue to the tumor. And we're learning a lot from surgeons who have, by their very nature, surgeons cause tissue damage when they try to get to the tumor. But they've learned over the years how to poise the tissue to heal after such an insult. We've never done that before in our field, but we're learning how to sort of approach the problem using radiotherapy as the knife and then still poise the patient to heal after this type of treatment. I think it's an elegant way of getting there, whereas surgery is still a rather crude way of getting to the target. And once we're at the target, it then becomes a very simple and bullying therapy to try to cause the tumor great harm.